And we're really blessed, and obviously you guys seem to know Linda Pham, so that's
So,
pretty awesome.
I've worked with some
Because I just met her.
No
So thanks for coming, and I'm
problem.
just gonna let you take it away and see where you're at.
Okay, guys, we have like 3 topics today, so I don't know what the time is gonna look like, so I'm gonna try to get through the topics. Stop me if you have any questions, obviously. So my name is Linda Pham. I'm a pharmacist with UC Davis. I'm an ambulatory care pharmacist. I work with the primary care physicians at the Midtown Commons Clinic, and I also work in the healthy aging clinic as well, sort of managing medications, managing diabetes, managing blood pressure. One of my side gigs is I work with one of our cardiologists, Dr. Putnam, to manage patients with heart failure. So that's sort of a side gig. I do that 1 day a week, and I support her that way. For her clinic in Folsom, I actually work remote from her because they don't have room for me. So I got kicked out of the clinic, and unfortunately, woe was me, I have to work from home that day. So, so today I have 3 topics prepared, as I understand that might be an area of interest for everybody. The first one's going to be medication use in the older adult. We're going to talk about, the thing, what happens to our body as we age and why medications become more and more problematic as we age. And we're going to talk about something called the Beers criteria, which is sort of a list of medications that we get very worried about. Not, don't ever prescribe, but medications we really need to be very careful with as we prescribe them in the older adults. There was also an interest in kidney health. So I have a short presentation on kidney health and how to manage, how to keep your kidneys healthy. And the last one I threw on, Sharon didn't mention it, but there was a presentation that one of my colleagues, Janine, had put together on Medicare drug plans. And so open enrollment is coming up on October 15th. So I thought I'd throw that in for those of you who want to kind of, talk about it a little bit. Okay. All right. With that, I'm going to go ahead and get started. We'll talk about medication use in the older adults first. Okay. Let's see. Click. Do I advance? Page down. Enter. Okay, enter. Okay. So our goal today with this presentation is just to understand what changes are happening in our body as we age, and then to discuss what the high-risk medications are of concern in the older adults. So what happens when we age? What happens to our body, right? We get more fat and we lose muscle. Just the natural aging process. Our body leans toward making more fat, and we start losing our muscle because, about after the age of 30, we stop building muscle. We can keep the muscles we have, but we sort of stop building muscle, and slowly we start losing muscle. We also tend to get more sedentary as we age. So there has to be a concerted effort as we age to exercise, to do strength training, to do cardiovascular exercises in order to keep the muscles that we have, because our bodies are naturally going to want to have more fat composition and less lean mass. In women, hormone changes, menopause causes our body to also lean toward keeping more fat than muscle. And the fat that we keep isn't the pretty fat. It's the one in the middle, right? It's the gut fat that we keep. It doesn't go to our legs. It doesn't go to our boobs. It goes to our belly, right? And so and it's a vicious cycle, right? We lose lean body mass. We lose muscle. When you lose muscle, the muscles are our main usage of energy, right? So you have less muscle, you have less energy use. So you're burning less calories as you lose muscle, right? So then the body says, I'm getting the same amount of calories that I'm always getting. I don't need as much of it because I have less muscle. So I'll store the rest as fat. And then you have this cycle, right? Of less muscle mass, less energy use, more fat, and it goes on. We gain weight. We gain weight between the age of 40 to 66. We gain about 1 pound a year. Right. So again, concerted effort. Without concerted effort to keep our muscle, to, keep our cardiovascular health, to maintain our body weight, we will tend to gain weight. Go ahead. After the age of 66. So there is studies that say we continue to gain weight, and I don't know why my thing went to the next slide. Is it auto
Oh,
going up? So after the age of 66, there's some studies that show that we continue to gain that pound a year until about 70. There are some studies that actually show we have a decline in our weight. We start potentially losing weight. I think most of it is from just eating less, or appetite and eating less. When we're a little younger, then we're continuing to eat the same amount, but moving less. So that's where the weight gain comes from. Well, most of the fat is the belly, but I mean it's distributed, but the majority of the fat it tends to deposit in our belly.
Sometimes like my face gets a little bit. It's narrow.
Yeah.
It's never narrow, but it seems to, when I'm not doing well, it seems to.
It could be also swelling though, right? And water retention. So depending on if you're gaining body weight, like, from excess calories, quick changes like that could be fluid shifts. So we also move from, as we age, we move from making our bones stronger to breaking down our bones. So our bones are always, from birth on, the body is always making bones, breaking down bones, making bones, breaking down bones. But in our younger years, we're making bones more than we're breaking down bones. But as we age, we make less bones and we're breaking them down more, right? Our gut also slows down. So, the food is sitting there longer, we get reflux, we get constipation. So our guts aren't moving as well as they did when we were younger. And our liver and our kidneys, this is probably on auto. So our livers and our kidneys, they have less functional cells. They're not working as well. They're actually even slightly smaller. Right. So what does that mean? Right. We have less muscle. We have more fat. Our guts are moving slower. Our kidneys and our liver is not working as well. And our bones are more brittle. We're not as strong. Right. We're not as strong. We have less abdomen muscle to keep our posture. We have less big leg muscles to help us when we're moving around. So our balance is affected, right? We're more prone to falling just as we age, and we have more brittle bones. So falling, I tell my patients all the time, I don't care if a 40-year-old falls. I say, get up, you're a little bruised, who cares, right? But, when a 70-year-old falls, an 80-year-old falls, that's a big deal. That's a big deal, right? Because our bones are more brittle. And we don't process medications the way we did when we were young, right? We absorb the medications differently. Our gut is slower, so we absorb the medications differently. Our kidneys and our livers can't clear the drugs as well. So the drugs stay in our body longer, right? And because we have more fat cells, the drugs that are fat soluble, right? So there are drugs that, oil versus water, right? They're fat soluble. Because they're fat soluble, these drugs, and we have more fat, these drugs stay in our body longer and they last longer, because once they're in the fat cell, then they start leaching out slowly. It's almost like that extended release formulation of your medication that you don't really want to take. So things like, I don't know, vitamin D, for example. I'll give you an example. Vitamin D is fat soluble. Vitamin C is water soluble, right? You take a little too much vitamin C, your kidneys just get rid of it, right? You take a little too much vitamin D, it goes into your fat cells and it starts accumulating. That extra doesn't go away because it stays in the fat cells and starts leaching out. So those become worrisome. So what do we do with meds then, right? We know these are the changes in our body. What do we do with meds? The American Geriatric Society developed a criteria years and years ago. They updated every 2 or 3 years called the Beers criteria or the Beers list. And this is a list of medications that's of concern in the older adult. And the criteria they have five criteria to get on the list. Medications that should be avoided in the older adult. Medications to avoid in adults with certain health conditions because they can make those health conditions worse. Medications to avoid that have a lot of drug interactions. As a pharmacist, I hate those drugs, right? I don't want to remember that drug A interacts with 10 other drugs. I want the drug B that doesn't interact with any drugs, right? Medications to avoid when the side effects outweigh the benefits, and medications to use in a limited capacity. Short term, not a problem. Long term may become a bigger problem. So the next set of slides is going to be a little dull. We're going to go through, the meds that are on that Beers criteria as a general.
Linda.
We're gonna turn your sound off.
They go through most of the medications, and the ones they highlight medications, they'll give
And we were,
recommendations
Here.
like use this drug instead of this drug, because this drug seems to have a little more side effects than this other drug. It's
You're gonna go through the list. Is that something that we should all have at home?
I would say yes, but with a grain of salt. Because it lists, if you look at the list, everybody's on something on that list. I can guarantee you, everybody, blood pressure medications are on that list, right?
But if
Yeah,
you feel ready,
Thank you,
like,
Paul.
talk to your doctor.
yeah, so it's something.
You're the monitor. You're the Zoom monitor.
Well, no, because I thought it was me.
No, it wasn't you.
Sometimes-
Both of these computers, they tried to,
Give you some-
Reboot, yeah, isn't that wonderful?
Mhm.
no, it said software update.
What was that?
It doesn't tell you, do you want to do it later? It just says we're doing
No,
it
yeah,
now.
that, it said snooze. You could, if you hit snooze quick enough.
Yeah.
Yeah,
But when you're in the middle of a meeting, you don't know that.
I know, yeah.
They do, right? So, and I'll touch on that a little bit because we're gonna go through this list and then everyone's gonna be like, oh my God, I should not be taking any medication that I'm on. None of the medication, I'm just gonna go home and stop taking everything. Because everything I take is on this Beers list. And because it is quite an extensive list. Because as we age, medications become of concern. But the problem is we need more medications, right? Our organs are aging, our body is needing more chemical support, right? So we need more medications when our bodies can't process them as well. And so it's you know, and I'll touch on that.
Do our doctors know that when we have automatic refills, do I need?
Yes, so on automatic refills, it would be because our system is so stupid.
Yeah.
You know, the doctor's prescription doesn't necessarily translate over to the pharmacy. If the doctor stops a drug, it doesn't necessarily stop it at the pharmacy. You as the in-between have to be the communicator yeah. So if the doctor says, stop your diuretic, right? They stop it in the computer. That doesn't necessarily tell the pharmacy to stop it. And so if you are on automatic refills, the pharmacy will keep on sending it until you tell them to stop. And so you have to be sort of the go-between. I recently, my husband was on a blood pressure medication and the dose changed. And I realized that CVS, their app is nice. Their app notified me and said, are you still on this drug? Can we stop it? Are you starting this new drug? But that's if you're in the app, right? If you're not in the app, then both are still active. I've seen many times, when drugs that have been stopped are refilled, the wrong dose is refilled because they had an old prescription that they refilled that was on auto refill and the new prescription didn't get on the auto. So you sort of have to be, you are the only one who knows what you take. The doctor doesn't know what you take. The pharmacy doesn't know what you take. You are the only person who knows what goes in your mouth. And so it's on you to have a list to make sure everybody knows what's on your list.
I have PBS also,
Mm-hmm.
and I think the app, it mirrors UC, my UCD.
It
So. I mean,
may or may not. Yeah, because they're two separate entities. They're two separate entities.
even though it looked very similar on the,
Mm-hmm.
on the notifications and stuff.
A lot of times, so new technology, when the doctor stops a medication, it does transmit to the pharmacy. But that's not a guarantee. I would say that works about 75% of the time from what I've seen. But it's not a guarantee. Yeah. And a lot of the physicians will give you refills, right? They'll give you refills because it's convenient. They want you on it and they don't want you to have to call in. You don't want to have to call in. So they'll give you a year of refills and then a month later they change the drug on you, right? They didn't mean to do that, but the pharmacy now has a year's worth of refills that they can refill for you. So, and then if the pharmacy doesn't get that messaging, it's not even the pharmacy's fault, right? They don't get that messaging. They're doing their thing. UC Davis is, or your provider is doing their thing. And the two just aren't necessarily talking.
Right.
Yeah. So you have to be the translator. You have to be the in-between. Okay. All right, let's go back to our list of medications that we were talking about. So as I mentioned, Benadryl, Unisom, diphenhydramine, anything that says PM, anything that says sleep aid over the counter. Try to avoid those. They're in they have this side effect called anticholinergic side effects. Anticholinergic side effects is in a lot of medications. They make you, they cause you to have blurry vision. They cause you to hold on to your urine. They cause you to get sleepy. They cause you to have dry mouth. Ultimately, we put all that together, they increase your risk for falls. Right?
Find the newer antihistamines would be
The newer antihistamines would be better. So these two are I highlight here, but loratadine, cetirizine, fexofenadine, descetirizine, I think, Xyzal, Claritin, Allegra, those are fine. It's the Benadryl and the Unisom. So anything that's a sleep aid over the counter is of concern. Anti-anxiety medications, your doctors, if you're on these, are probably always trying to get you on as low a dose as possible. They do cause memory loss. They do cause changes in mentation. They do make you sleepy. They do make you discoordinated. Older antihistamines, we try to avoid these, but physicians will use these once in a while, amitriptyline especially, as a sleep aid. because they make you sleepy. They make you sleepy, they make you drowsy, but they have that anticholinergic side effect that is of concern. You know, the dry mouth, the blurry vision, the drowsiness, the discoordination, the, you know, urinary retention, right? And then blood sugar lowering agents. And I highlight these particular because there are newer ones that are very safe. The newer ones are very safe. But insulin and what we call the sulfonylureas or the glipizide, glimepiride, glyburide, these medications don't care if you ate or not. They don't care if your blood sugar is super low. These medications don't care. They just keep driving down your sugar, which is problematic, right? You live by yourself. It's a problem. So these are of concern. A lot of older adults are on insulin. A lot of older adults are on glipizide. It's one of those things we try to minimize. And now that we have the newer agents, which are a lot safer, I as a pharmacist always try to move patients onto those and try to get them off insulin and glipizide specifically. Hypnotics. As we get older, we have more difficulty sleeping. We need sleep aids, and sleep aids are a problem. Sleep aids are a problem because they make you drowsy. That's what they're supposed to do, right? But our bodies process them differently. We get up in the middle of the night. We're still groggy. We're still discoordinated. We get up in the morning. We're still groggy. We're still discoordinated. Again, increased risk. This is for altered mentation, right? Medications that alter behavior, antipsychotics. Our younger patients are on it for, you know, mental illnesses like schizophrenia. Our older patients may be on it for dementia-related behavior. We use these very cautiously and as a last resort because they can cause altered mentation. Bladder control medications. So as I go through these, you're like, well, you know, these are problems in the older adult, and we have medicines for them, and the medicines are a problem, right? You know, the symptoms are a problem, and the meds are a problem. So bladder control medications, we do have newer ones, Gemtesa and Myrbetriq, that are a little safer. Oxybutylene, again, with those anticholinergic side effects, is a problem. Muscle relaxants because they make you drowsy and confused, and then opioids. Opioids are good pain medications. We do have a couple safer opioids now that we try to move our older adults to. Buprenorphine is the one we use. It is still an opioid. It is a little bit safer, so we try to move our older patients, you know, off of opioids as much as we can because of the risk for altered mentation. Medications that increase risk for falls. See how familiar this list is? It's the same exact list pretty much, right? Your Benadryl and your Unisom, your anti-anxiety medications, this is the exact same list, right? They increase your risk for falls. And as we talked about, our bones are more brittle. We're weaker, we're walking a little less steady, and adding these medications just increases our risk. In addition to the same list, and I don't know why I put it right in the middle, but blood pressure medications. Blood pressure medications because they lower your blood pressure. They can make you dizzy. You know, for our older adults, we tend to be a little more lenient with the blood pressure control because the lower you make the lower you aim for blood pressure, the more likely you're gonna aim too low. You're gonna get too low. So we give our older adults a little more leeway. The American Diabetes Association recommends a blood pressure of less than 140/80 for our older adults. The American Heart Association still sticks to their less than 130/80 with an asterisk. You know, they say, well, if you think your patient's at a risk for fall, maybe this isn't a hard and fast rule. And so our blood pressure medications can be a problem. Medications that are on the list because they can have bad side effects. Low dose aspirin. A lot of older adults are on low dose aspirin because years ago we told everybody needs to be on a low dose aspirin. It's fine. Everybody needs to be on a low dose aspirin. It's great. And then maybe about 5 or 7 years ago, they went back and they said, oh, wait a minute. We're probably not getting as much benefit as we think we are. And we're getting some side effects. And so now the low-dose aspirin is off the list for recommended as prophylaxis unless you have some sort of heart disease, heart or vascular disease, and your doctor recommends it. So in general, I don't recommend just kind of taking a low-dose aspirin because you heard it was good for you. Acid reducers for long-term use. We have peptic ulcer, you need an acid reducer. So long-term use can increase your risk for pneumonia, increase your risk for bone fractures because they demineralize your bones, and potential of stomach cancers. Non-steroidal anti-inflammatories for pain. Just over the counter is more concerning because you have access to it, right? Ibuprofen and naproxen. Those can damage your kidneys and they can cause stomach ulcers. Yes.
As the non-steroidal medications are okay to use. Do you have any?
Not really. Yeah. I mean, meloxicam is supposedly a little safer on the stomach. It is still at risk. So you'll see meloxicam or Mobic prescribed quite a bit. If I need an anti-inflammatory and Tylenol doesn't do the trick, I usually reach for meloxicam.
Oh, it's okay.
Tylenol is okay. Tylenol is perfect. Tylenol is beautiful. Tylenol is water. As long as we stay under the 3,000 milligram limit, Tylenol almost has no side effects. So let's see, we were on, where were we on? Bad side effects. Okay, aspirin, acid reducers, and then water pills. Water pills can cause kidney damage, and a lot of our, heart patients are on water pills. So they can cause kidney damage. And if you think about it, when you have to go on a water pill, you have to go now, right? It's not like I can wait 5 minutes, you got to go now. So you're rushing and that increases your risk for fall, right? Let's see, blood thinners. Blood thinners because, if you fall, then they can cause badness. Blood thinners in and of themselves are fine, right? As long as the blood stays where it's supposed to in your blood vessels, then they're fine. But it's when you get the stomach ulcer, it's when you get the nick in your, skin, it's when you bruise yourself, right? That's when they can cause problems because the bleeding has a more difficult time stopping because you're on a blood thinner. And then, as I mentioned, some anticholinergics on a lot of medications, antihistamines, bladder control medications, antidepressants and antipsychotics, blurry vision, urinary retention, dry mouth, constipation, ultrapigmentation. So these are of concern. So word about kidney damage. Everybody goes, I don't want to take it because it damages my kidneys, right? Kidney damage from medications is what we call acute. We take the drug away, the kidneys get better, right? So a lot of times it's your doctor will say, I need you to go to the lab. Go to the lab. Don't put it off. The earlier we catch it, the earlier we can adjust your medications, and the sooner your kidneys will recover. So it's not as scary. It is scary and it's not scary, right? We can work with that. We just need to know. A word on herbal supplements. Things to consider when you're on herbals. So because a lot of us are sort of reaching. It says it's good for my kidneys. It says it's good for my memory, right? Most FDA supplements are approved. They're approved as supplements, not as medicine. So they're approved as being safe, but not approved as being effective. Right? I tell my patients this: if it really worked, they would have gone to the FDA, gotten approval for it, gotten a big old patent, and charged thousands of dollars to the insurance, right? They're not doing that because they don't have the studies. They don't have the studies to show the FDA. They have some junky studies maybe to tell you they did studies, right? They have studies to tell you they did studies that it worked. But if they present those studies to somebody to scrutinize them, then it may not qualify, right? Beware of proprietary formulas. Proprietary formulas, patients will give me the brand of something they take, and they say, does it interact with any of my medications? I have no clue. I have no idea what's in it because it's a proprietary formula. I don't know what's in it. I can't tell you. Yeah. Scrutinize that clinical evidence. Again, if the studies were so great, they would have gotten FDA approval for it. Yeah. And then beware of anything that says a diet or energy supplement. I've had too many patients come in and tell me, oh, I feel tired, so I'm taking this energy supplement, this diet supplement. Those almost always contain caffeine, and at high doses, usually between 2 to 4 cups of coffee equivalent in those supplements. So
And
just
I'm
beware of
trying-
those. Oh, sorry, that was my colleague's slide that I didn't delete. So what should I do? Like I said, after hearing that, you're like, I'm on all these meds, I need to just stop. I can't be on any of this, right? It's a risk versus benefits game. Am I getting benefit from this medication more than the risk? I'll tell you, heart medications, they're not like pain medications. They don't make you feel better in an hour, right? Some of them can make you feel worse, right? Some of them, the hope is that you don't feel anything at all, that you're taking the pill, but they're not having side effects for you. But, our heart medications can lower our blood pressure. They can make us tired, right? The goal for those medications is the long goal, right? In 6 months, in a year, in 5 years, you're going to be better off on them than you're off of them. How do we know? Because we have studies. We did studies where we gave one person no med, one person the same med. 10 years down the line, we're like, dang, this guy lived longer, right? This guy's kidneys were better. This guy's heart was better. And so we move that forward and we give it to our patients now because it's the long game. It's hard to see when you're tired, when you're opening 10 bottles, right? It's hard to kind of go, okay, I'm doing this because I'm going to be better off in 5 years, right? That's hard to see. But really, that's going to be the long game, benefit versus risk. If I have to be on this drug, how can I lower my risk, right? Can I do with less? Can I do with less? Oops, this keeps on wanting to advance. Is there a safer alternative? We talked about the NSAIDs. Tylenol is a safer alternative. Will that work just as well? Right. And then do I just need to monitor this often? I have to be on this drug. The benefits are going to be good for me. How do I lower my risk for the adverse event? Do I need to, see my doctor so often? Do I need to get blood work? Do I need to monitor for some symptoms before to tell my doctor? And then again, do all my doctors know what I'm taking, including my herbals? Do they know what I'm taking? So because only you know what you're taking.
Can I ask a question?
Sure.
Will you be talking about drugs that potentially might cause you to get dementia?
No.
Okay,
Mainly because the altered mentation drugs, so this class of drugs here, these are the ones that cause confusion. Getting that feedback. If there were there aren't many drugs that have been shown to cause dementia.
the reason I'm asking is AARP just put out something about research being done on gabapentin, which is
Mhm.
Neurontin.
Mhm.
And that's the only drug that I saw on the list that I take that they said causes dementia.
They say cause, or they're researching it.
No, the research was done. I believe the research was already done.
Okay, I'll be honest, I don't know about that. I wouldn't be surprised. Gabapentin works on our brain and slows down our brain firing. I wouldn't be surprised. I don't know that hot off the press. If it
Okay,
was.
thank you.
Yeah. Okay. Herbal supplements, we did this slide. We did this slide. So other things you can do, stay active, right? Strength training, why you guys are here. Strength training, cardiovascular. Strengthen your core to help with your posture, strengthen your legs to help with your movement. And then continue with your cardiovascular exercises to lower your blood pressure, to improve your endurance and to improve your heart health. You eat healthy. Stay below your sodium limit. This is a sodium limit that's been told to every heart patient. It's a sodium limit recommended for everybody. You know, the 20-year-olds should be, below 2,300. Everybody should be within their, below the sodium limit. It lowers your blood pressure and it decreases stress on your kidneys. Follow a more plant-based diet, which means less animal protein, or a Mediterranean diet, which is relatively plant-based with whole grains, more fish and poultry instead of red meat, olive oil, and less sweets. It lowers your blood pressure, decreases your risk for cardiovascular disease, and helps you maintain a healthy weight. All right, that's the medications portion. Any questions? Oh.
I have another question about the insulin that you mentioned.
Uh-huh.
How do I know if I'm taking the more modern insulin? I'm taking, metformin, I think it's metformin, and I'm taking 2 types of insulin injected by needle.
If you're
I don't-
taking an insulin that's once a day, then you're on the modern insulin. The older insulins you have to take 2 to 3 times a day. There is a fasting insulin as well, a mealtime insulin that you take with each meal. that is
Yes,
shorter hours.
Humalog.
Yes, yep.
So is that something I should be concerned about?
You should be concerned that you're on insulin, but you are on the correct types of insulin.
Okay,
That's a general concern, not a, you're not on an older insulin.
okay.
Okay.
Can I ask a question about the omeprazole? I'm on,
Yes.
I've been prescribed to take it every single day.
Mm-hmm.
Is there anything, Barrett's esophagus, GERD,
Yeah.
a bunch of things going on with the gut.
Yeah.
Is there any way to minimize potential side effects from the omeprazole?
Omeprazole can deplete your magnesium. So, every 3 to 6 months, making sure you check your magnesium level. That's where the, bone issues come in, is when depletion of your magnesium. And then if you've tested lowering the dose, it's every once in a while, just reassess, can I try a lower dose? And at this point, and with Barrett's, I believe that you have more benefit than the risks would warrant taking you off of it.
Okay,
Yeah,
thank you. Thanks.
no problem. You had a question, sir.
Do you want to use the mic? That way everyone.
We need to get rid of the commercials on TV for medicine.
We do. I heard a rumor that was going away because I hated it when it started. Yeah, those commercials are, they're not just a, in my opinion, they're not just a clinical concern, but they're a drain on our healthcare system, right? They're monetarily a drain on our healthcare system.
Comment on you.
Mm-hmm.
I was on that for like 15 years. And I said, why am I still on this? And I haven't had acid reflux in years. So I told my doctor, I said, I'm going to wean myself of it. And I did.
Yeah, it's reevaluating these, especially when they're symptom medications, right? If your symptoms got worse, so you go off of it, or you lower the dose. Every once in a while, test the waters a little bit and see if you can get off of it. Yeah.
Thank you.
No problem. Okay. I'm gonna go, it's 12:30. I'm gonna go through the next one. This one should be pretty quick because you'll see why. There was an interest in kidney health. How do I keep my kidneys healthy, right? So we're gonna understand what the kidneys do, and then we're gonna talk about ways to improve your kidney health. Okay. So what do our kidneys do? Our kidneys do a lot more than you think. We think of them just as our filter, right? But they maintain our fluid balance. So they dilute out any extra sodium we take in. So sodium is a very important element. All of them are important, but sodium is important in our body because it helps maintain a fluid balance between our brain and our body. So it gets rid of extra water that when you drink too much. It holds on to water when you're dehydrated, and it maintains blood pressure. It keeps your electrolytes balanced. It keeps potassium balanced. Potassium is involved in electrical circuitry, right? Our heart circuitry, our muscle circuitry. Potassium is what they give you on death row, because that's what's gonna mess up your heart circuitry. Phosphorus is involved in maintaining our bone health. Phosphorus, along with vitamin D and calcium, is involved in keeping our bones strong. And sodium, as I mentioned, keeping our fluid shift between our brain and our body. It helps with blood cell production. It produces a protein called erythropoietin that goes to our bone marrow and helps our body makes red blood cells. It maintains our bone health by activating vitamin D. So when you take vitamin D, it's not actually an active form. It has to be activated by the kidneys to a form called calcitriol in order to work with phosphorus and calcium to maintain our bone strength. And then it filters our blood. It gets rid of the toxins, and it's involved in getting rid of many of the medications. Are there any medications to keep my kidneys healthy? No, there isn't. You'll find supplements that say they do, right? There really isn't medications to keep your kidneys healthy. Our kidneys are pretty resilient organs. They can handle a lot. But how can you keep your kidneys healthy? Control your blood pressure, control your blood sugar. That's how you keep your kidneys healthy. Right? So there are certain blood pressure medications and blood pressure medications that have been shown to be kidney protective in those that are already at risk because they have diabetes, because they have high blood pressure. Your doctor may choose to give you either an ACE inhibitor or an ARB. Lisinopril, benazepril, losartan, those have been shown to be kidney protective. Newer diabetes medication and heart failure medication, the SGLT2s. This is your Farxiga, your Invokana, your Jardians. Those have been shown to be kidney protective. And the diabetes injectable, semaglutide, otherwise known as Ozempic or Wegovy, has FDA approval for kidney protection as well in the diabetes patient. So this is protective in patients who are at risk. The healthy patient shouldn't be on these because their risk outweighs their benefit, because you're not as high a risk for kidney damage. What can you do? Again, control your blood pressure, control your blood sugar, lower your salt intake, right? The higher your sodium intake, the more your kidneys have to work to dilute that down. The more your kidneys work, the more they hold on to water, then the more likely you're getting more pressure onto your kidneys. Your kidneys have these tiny, tiny little things called glomeruli. Just think of them as the filters in your air conditioning. They're tiny, tiny, and they're very sensitive. So you add more volume on them, you put more pressure on them, they can get damaged. So lowering your salt intake helps lower your blood pressure, helps decrease your body overall volume, decreases stress on the kidneys. Okay? And then hydrate. If you're told to limit your water intake, maintain at least 48 ounces, right? Up to your limit. At least 48 ounces keeps your kidneys well hydrated. Okay. And then what generally you're looking for, pale yellow in your urine. Unless you're on medications that turn your urine orange, there are some. Pale yellow is what we're looking for. The darker your urine, the more you need to hydrate. Because your kidneys are now holding on to water, right? Exercise decreases your blood pressure, less strain on those tiny little glomeruli. Quit smoking. Right? If you're smoking, quit smoking. They harden your arteries. And again, those low glomerular filters are at risk. And then minimize the use of kidney damaging medications to the extent possible. Right, Tylenol versus naproxen. If you're on a water pill, minimize your sodium intake, so potentially you need less of it. Okay. And that's it. That's my kidney talk, because there's not, I Googled it. There's so many supplements out there that say kidney health. I don't know what they're about, honestly, because there really isn't. They're just kind of tapping onto the desire, the need that we're all looking for.
There's a commercial that's for, when you're on statins.
Mm-hmm.
There's a woman, she's talking.
CoQ10.
Yeah, is that recommended or?
CoQ10. So my take on supplements is they're safe. They're not necessarily effective. CoQ10 had a study that showed that it was good to reduce muscle, weakness and damage from statins. And then there was another study that said, nope, didn't do anything. Right. So now you have conflicting studies. And the evidence leans toward it doesn't really work. So that's where the evidence leans, that CoQ10 doesn't work. And so, most patients will take it. Most cardiologists can recommend it, right? It doesn't really hurt. If you want to try it, it doesn't hurt to try it. Yeah, but the evidence sort of leans toward it not working.
Thank you.
Welcome. Any other questions? Yes.
I have two questions. Sure.
I was wondering what effect beer has on kidneys, salt wise or fat wise. I know we can have a fatty liver. Can we have a fatty kidney? And also, I was wondering if vitamin D is activated more if you're out in the sun. That was an old wives' tale. At least get like 15 minutes of sunshine every day to activate vitamin D in your body.
Yes. So let me, the beer question, beer is empty calories. Your body doesn't do a lot with beer. So you get empty calories that have no benefit. And so that's beer. The alcohol itself, excess beer obviously can cause liver damage. Excess alcohol can cause liver damage. From a kidney standpoint, it's more about the gaining the weight, the changes in your blood pressure with beer. There's no sodium in beer. It's just it basically is alcohol with flavor. Well. Okay. And then what was the other question? You had another question. It was vitamin D. Yes, you need sunshine helps make vitamin D. Your kidneys then convert it. So your kidneys are and yes, sunshine does help you produce vitamin D. The vast majority of us don't get enough sunshine because we shouldn't be out in the sun and sunbathing anymore, right? So vitamin D supplementation is generally safe and recommended. Only 1,000 to 2,000 international units a day, no more than that. I know it comes in 5,000s, and I have patients on 5,000, which is too much. So it is one of those fat soluble vitamins. So if you have 5,000 at home and you're like, oh crap, I shouldn't be taking this every day, you can start taking it just once a week until you use up the supply, because remember, those fat soluble stuff sticks around. So you can, they last a little longer in your body. Okay. Any other questions? All right, I'm going to touch on on Medicare real quick, because we're going into open enrollment. How do I switch to the other one? Is it? Okay, there it is. So this is a presentation by my colleague. Again, oh, it's not in sync? Is that doing anything? I have to share again?
Maybe.
back in sync.
Drug costs?
Okay. So the first set of these slides, talks about, you know, how to decrease your drug costs, right? I'll go through them real quick. It's not, oh, there it is. Brand versus generic. You know, generics are just as good as brand. There are a small population, very small population of patients in which the brand is because of the excipient, or they're very sensitive to the drug itself. Thyroid pills come to mind, where the brand does make a difference. But for the vast majority of us, 99.9% of us, the generic works just as well. They're a lot lower cost. An example here is atorvastatin is about $18 for a 90-day supply versus Lipitor, which is about over $1,000 for a 90-day supply, right? So it's a big burden on our healthcare system when we're unbranded when we don't need to be, right? You know, we all get worried that Medicare is going away because Medicare is, you know, getting bankrupt. And some of it is because of these newer, you know, these little bits that are eating away at our system. So Medicare, you guys might already know this, but Medicare, there's 4 types of Medicare, right? There's A, B, C, and D. Everybody should have A, B, D, or C. C is your Advantage plans, your Kaiser plans, your HMO plans, the all-in-one plans where you get, you know, hospitalization, doctor's visits, and drugs. A, B, and D are your separate plans. A covers your hospitalization, B covers your outpatient visits, D covers your drugs. If you're on an HMO plan, like a plan C, they tend to be cheaper, you know, because they control the cost. You know, one company controls the cost. They tend to be cheaper. However, they also limit where you go. HMO plans, Medicare C plans will restrict you to this group or that group. A lot of patients will ask me, I see the United Healthcare Medicare Advantage plan is cheaper. Can I go to that? And I said, you can go to that. I'm not 100% sure you can keep all your doctors, because that their group may be different. So it requires a little scrutinizing to make sure if you go from an ABD plan to a Medicare Advantage plan, if you want to keep your doctors, to make sure your doctors accept that exact plan. So drug plans. Drug plans, in 2006, the federal government privatized our drug plans. So that's why we have a drug Part D every year, October 15th to December 7th, every single year, same dates. October 15th to December 7th is open enrollment when you can change your drug plans. And I recommend everybody do it. Not change their drug plan, everybody reevaluate their drug plan. Unfortunately, you can only reevaluate your drug plan based on the current meds you're on, right? You know, a lot of patients go, well, I need to be on this plan because what if I get on this really expensive medication? You can't, it's hard to plan for the future and pay a lot. So if you're okay paying a lot, I've had patients come in where I say, why are you on this $120 plan? There's like a $1.50 plan that is gonna have the same copays. Well, I've had it for years and I was worried I wanted to be on the, you know, the Cadillac plan, but you don't need the Cadillac plan. You know, you're on 5 generic drugs. You don't need to be on the Cadillac plan, right? And then, you know, if you don't like your plan, you know, open enrollment is the only time you can switch. So that's also the fear. HiCap is a great organization. They're a nonprofit. They do Medicare counseling. So they can help during open enrollment if you want to reevaluate your plan. You know, there are private, you know, insurance brokers that can also help. They do charge a fee. But I'll show you how simple it is. For those of you who are comfortable on the computer, I'll show you how comfortable it is. Okay. I'm not going to talk about the donut hole because it's gone. So here's the website, medicare.gov. You go to medicare.gov, you hit modifying your drug plan, you can create an ID so that, you know, the drugs that you put in are saved. So when you go back, or you can, you know, not create an ID and just start by putting in your zip code and what kind of plan you're looking for. Most people during open enrollment will be looking for a Part D plan, right? So that's what, 10 seconds right there, right? Medicare.gov, find a plan, put in this information. And then you put in, then the next screen, which is not on here, you just put in your drugs. You just put in the list of the drugs that you're currently on. And then Medicare does Medicare, what I call Medicare math. They look at the list of drugs you're on. It'll ask like what pharmacies you want to use. Yeah, it'll ask your drugs and then it'll ask what pharmacies you want to use. Put in the 4 biggest pharmacies. You know, put in CVS, put in Walgreens, put in Costco, put in Safeway, right? Because you want to, because if you don't care whether you use CVS, you know, down the block or Walgreens 2 blocks away, you want Medicare to evaluate the plan that is cheapest for you if you move pharmacies, right? So put those big ones in. And then Medicare does Medicare math. It then calculates based on the premium, based on the copays, based on your drugs, which plan is going to be cheapest for you, right? It may recommend a plan that has a deductible, right? But by December 31st, you'll save $2,000. Even though on January 1st, you're paying $700, right?
Hi, Betty.
So it'll organize it in that fashion. And then you can click on it if you want details. Why is it $2,000? So it shows it like this, right? Where for this particular person, there's 3 plans. There's WellCare, WellCare Script to WellCare RX and Mutual of Omaha. There's the different, look at the 3 different premiums, right? $8, $71, $100. And then there's a, look at that. This is what I've seen. Patients, the $100 plan person still has a deductible. The $8.30 patient has a deductible, same deductible, but every month you're paying $90 more, right? And then it'll tell you the preferred pharmacies and how much the drug is going to cost for the year, right? Mutual of Omaha, $16,000, right? Based on this, and the WellCare, $2,800. Big difference. And this is probably, depending on how long it takes you to put in your med list, this is probably about 15 minutes into visiting the website. So not a lot of time commitment. It'll tell you the preferred pharmacy and the non-preferred. So in-network means your copay is a little bit higher, but it may be that, you know, the Walmart is a block away and the Walgreens is, you know, 5 miles away and you need a ride, right? So that may change your plan selection because you want the one that's the preferred plan, the one that with Walmart in the preferred network. But as a Medicare recipient, you can use any pharmacy you want. You're not restricted to any pharmacy. You just get a little bit of a copay benefit if you use one pharmacy versus the other. When you click on the drugs in the Medicare website, it'll give you the details. You know, what the retail cost is, what the drug cost is going to be after you've met your deductible, if you have a deductible on the plan. It's a pretty nice website. It's very well done. For us at UC Davis, we do offer during open enrollment pharmacist visits. So I do this quite a bit, and all I do is pull up the website and I start putting in drugs and I go, here it is. Medicare did all the work for me. And this is what Medicare recommends as the lowest cost drug for you, plan for you. There is something called extra help. If you qualify for it, it may be worth looking into. If you're a very low income, extra help lowers the copays down significantly to probably less, but your income has to be pretty almost Medi-Cal level income to qualify. But this is through the federal government, through Social Security benefits.
Going back to the plans. You said when you have Medicare, you can go to any pharmacy, but does that mean you have access to any plan? Or is
No.
Access to plans is restricted based on.
It's based on geographic. So that's why when you first go into the website, they'll ask you your zip code. So only certain plans are available in your area. And you know, like Northern California or the plans in Nebraska are different than the plans in California. Yeah, because it's privatized. So it's whatever plan wants to work within California.
And if you had done the C option and had assigned your Medicare to a HMO, are they the same plans or they're different plans?
There are different plans. There are different plans. There's PPO plans, HMO plans, PPO plans where you can, you know, you have a wider net of providers, HMO plans where you have a smaller net of providers. Yeah. I just caution, because everybody takes Medicare A and B, right? Everybody takes Medicare A and B. Medicare C plans, just make sure if you're looking at that, it is a lower cost option. If you're looking at that, then make sure if you want to keep your providers, talk with everybody. You know, call your doctor's office, you know, call the plan. I've had patients call the plan and the plan will say, oh yeah, your doctor's on the list. What they didn't look at, what the person on the phone didn't look at was, I'm gonna make up a plan, you know, Mutual of Omaha, HMO versus Mutual of Omaha, PPO. Right, so they didn't look at the difference, they just said, oh, your doctor's in network, you're fine. And then come January 1st, suddenly they get a call from UC Davis saying, we don't take your plan. You have to find new doctors. So I've had that happen to patients. And so it's just, I think they're good plans. It's just making sure that the plan you pick is accepted by the doctors that you have. Yeah.
I'm just curious, do most of you tend to do the Medicare C where you've assigned your Medicare to a Kaiser or an HMO? Some of you have, I know. Most of you probably not. You have. You would enroll in a second.
Yeah, Kaiser.
Right. So it's a mixed bag, it sounds like.
Yeah. I will say with D plans, specifically if you have a D plan, if you can, preferably, I would recommend assigning it to your Social Security benefits. You know, you can have them draw it out of your Social Security before you get your payments. I've had patients whose credit card expired, you know, and they accidentally didn't pay their plan for 2 to 3 months. The plan sends email, I don't check my email, right? And they get dropped from their plan. You get dropped from your plan, you cannot get back in until open enrollment. You are without a drug plan until open enrollment. Yeah.
C?
Hmm?
That's C.
That's D, drug D, plan D.
I mean, D.
Yeah, that's D. So I generally recommend, because your Social Security check's gonna always be there. They can always draw from your Social Security check. If you know, make payments outside of your Social Security check, anything happens to that credit card, anything happens to that bank account, because you closed it, because, you know, there was some fraudulent charges, you closed it, they can't make to pull their bill 2 or 3 months later, you're dropped from the plan. So, that's generally what I recommend, is to have it draw out of your Social Security.
The interesting is not automatic, but it can go from Social Security.
Yeah, well, you know, it gives people their, you know, I think that's always a sucky part. Yeah. Yeah.
Right, but those that do have Social Security, the Social Security automatically takes the A and the B.
Yeah,
You never had to request for that. It's interesting that the D is.
the D is optional. Yeah. Yeah, I've had an instance where I forgot to pay my car insurance. I didn't pay my car insurance for a month. I realized I was driving around without car insurance. I called my car insurance. The next day I was insured. That doesn't happen with D plans. You get dropped, you're waiting till January 1st of next year. That's it. Yeah. Yeah. Okay.
I was say, do you have any opinion of the Amazon going to funds? I mean,
It's,
just
I deal with them very little, because I don't have a lot of patients who use them. There are a couple of insurance plans that are moving to using Amazon as their mail order. So we're probably gonna see more and more of them. They're a pharmacy. They're a pharmacy. They're just like your Optum RX, you know, They do have some deeper discounts for cash pricing. For some medications, some generics mostly. They do this nice thing called pill pack, which is compliance packaging. Our local pharmacies do, if anyone's ever interested in that, we have small local mom and pop pharmacies that do compliance packaging. The one I like is, they call it the sleeve. Think of it as like a toilet paper roll, right? And you have the sleeve, yeah. Do you have it, or did you have a question? Oh, yeah. No, it's so they package your meds in individual squares, all in one roll. You know, the first one you pull off is 8 a.m. meds. The next one that comes after that is your 2 p.m. meds, and the one after that is your, bedtime meds, and then it keeps going. I do like those. They're only good really if your meds are stable. Because you have one change in the middle of that, then you're unrolling the entire sleeve and switching it out. So only if you've been on the same medications, there's no plan to change it, are those really nice and beneficial.
Can you get a sleeve for each drug? So
Huh?
here's my Centerville sleeve, and here's my.
Would you like to do that versus opening a bottle?
I don't.
It's I've had that accidentally happen. And patients are like, well, how is this any helpful to me? I go, it's not.
Is it like the denture tablets, when you tear,
Mhm.
you tear it, and
Yeah, it's like little pouches
yeah,
that
that's
are
the
all,
denture, yeah, things that you tear them apart and you tear them.
yeah, it sounds like it. Oh. Okay.
One quick last question.
Yeah.
One time, I used to with Kaiser, and I used to get it in the mail,
Mm-hmm.
and between the time I reordered a refill and saw my doctor, he changed my dosage.
Mm-hmm.
And I bought the thing in the mail. I never opened it. It was still in the pouch. They couldn't take it back. So even if it's not,
Yeah.
and that's becoming, I can understand if I thought of it thing.
Yeah,
But-
legally, they cannot take it back. It's the law. The pharmacy cannot. If you walked up to the counter, even when you walk up the counter, you pick up the medication, you walk out to your car and you're like, whoa, that's not the dose I ordered. You walk back in, they're like, nope, can't do it. Yeah, they can't do it. It's legally, they just don't know what you've done with the drug. If you've left, it could be intact, but you could have left it in the oven. So they can't take it back and give it to somebody else because it could be adulterated or altered in some form. So legally, pharmacies can't take it back. Yeah, always when you're picking up medications, especially if it's a high cost medication, double check it right there in front of them. That's what I always do. I open that brown paper bag, I pull the bottle out, I look and make sure it's what I had ordered.
While you're still.
Hmm? Yeah, while you're still at the counter, you walk away, they're not taking it back.
If you hadn't walked away, they would take it back.
Yeah, you haven't accepted it. If you haven't accepted it. Yeah,
And then can they reuse it?
yeah, they can,
Oh,
because it's still in their control or their oversight, if you will.
because they asked me my birthday
Mm-hmm.
and I signed it, but they have it stapled in the bag and I just walk out. So next time before I walk away,
I generally always open it right there while they're doing their computer thing. I open it, I pull out the bottle, I go, okay, that's what I,
see, because they staple it, so I
Yeah.
just.
yeah. So, I mean, the way the pharmacy works is they get the prescription, a technician fills it, human eyes, human hands. A pharmacist double checks it, human eyes, human hands. The technician puts it in the bag, human eyes, human hands. You just get the holes in that Swiss cheese all lined up right, and you've got the wrong drug. Right, there is another way to check, I don't know if you folks know, on the label, at the tiny print at the bottom of the label usually is a description of the pills inside. That's another thing I do, is I make sure, especially if they're not in their original bottles. And the original bottles, I'm pretty confident that that's correct, but if they're in the pharmacy bottles, read that and it should say green oval tablet with RM. Do I have a green tablet? No, it's white. Oh crap. This isn't the right man.
If they get the same medication from two different manufacturers, though. it can look different.
It can look different, yeah, so that's why the labeling is there.
Yeah.
So that was added probably between 5 to 10 years ago.
It can even be a different color, a different.
It can be, yep, so that's why on the label, you can double check it, going, this isn't what I usually get. Then you can double check and make sure what they put in the bottle is the correct drug. Mm-hmm. Okay, any other questions? Yes, sir.
About a dozen or so years ago, I was in Austria briefly, and I had got my Q bar.
Uh-huh,
Kaiser. So I went up to a local mainline pharmacy there, and I had, I Kaiser, you needed a prescription card.
mm-hmm,
There in Austria, you did not.
no,
And I was told no one certain, but terms by the pharmacist, no, I don't need a doctor to do this. I'm just highly independent. Where here, the neurological thing.
I think some of it is the pharmaceutical company. I think some of it is the pharmaceutical company, but I think our FDA is a little more stringent in terms of oversight, right? What the concern with being able to purchase some drugs over the counter is that you're self-treating a condition that you may be treating wrong, right? So you have, asthma, COPD, you're having some breathing problem. In Austria, they were thinking, this is a safe drug. It's super safe and, so leave it over the counter. But then what if it ended up being lung cancer? And you have breathing problems, you go to the pharmacy, you use this inhaler, you continue to use it, you keep using it because it's working, but no one's actually seeing, is there some other issue involved? And I think that's where we in America differ a little bit in terms of, like if you acid reducers over the counter, if you look at the label, it'll say not to use more than 2 weeks. Because if a doctor needs to evaluate whether or not there's an underlying condition.
Something else I think that's important is for the integrity of the medication. If it says don't store it in a damp area, where you're storing what we need to follow those directions because it can break down
Yes.
the drug itself, can that not?
Yes, the medication cabinet in the bathroom is the worst place for the medications. Right, because that's where we shower. That's where, our hot steam is, right? And yes, so humid conditions can alter.
My last question is, should, maybe not so much in my tablets or capsules, but like my eye drops, should I always be at the same time, or does it matter if you could, like, at one day I do it at 9 p.m., next time at 11 p.m., or
Yeah.
it doesn't?
No, my general rule of thumb is, plus or minus 2 hours for, twice a day medications, plus or minus 4 hours for daily medications.
So it's only-
Did I make that up? Yes, I did. Don't ask me for studies on it, but in general, if you take an 8 a.m. medication that's once a day, by 12 p.m., I'd rather you remember to take it than skip it altogether.
Not true, I mean, don't double it.
Yeah,
Just-
yeah,
If
yeah.
you missed it, one day you just missed it.
Yeah, if you completely missed it, don't double up, for sure. Yeah, yeah. Well,
You also said, take it before you eat.
yeah, if it says take it before you, staying within your dosing schedule. Yeah, yeah. Okay.
Linda,
Yes,
may I,
uh-huh.
can I just ask for your comments on two things?
Uh-huh,
Red yeast rice,
uh-huh.
and that's not if somebody has a severe cholesterol problem, but just
Got
in
it.
general. And the second one is taking the absolute lowest amount of CBD to help with sleep. A number of my neighbors in my age group and our doctors have even seemed to mention and be okay with that. So
Yeah.
those two things, any comments you have? Thanks.
In general for CBD, so this is CBD with THC. to
Correct.
clarify, right? So CBD alone doesn't do squat. CBD with THC at lowest amount, I think is okay. Can I can I say that as a recommendation as a pharmacist with my license? No.
Yeah.
But I can say it's, I think most physicians will,
Yes.
the physicians I've worked with have been okay with that. Versus our, you know, more potent sleep inducers, right? Our hypnotics.
Right.
Red yeast rice, if you're taking red yeast rice, you're essentially taking a statin.
Mm-hmm.
That's really what you're taking. So I guess my comment to that is, why not a low dose statin? Right? If you're gonna take red yeast rice, because that's what it is, right? That's why it works, because it's a small, tiny, low dose statin. You're gonna have the same side effects if you're gonna have them as statins. So why not just a low dose statin? Half a tablet, quarter tablet of the lowest dose. At least you know it's the formulation is an approved formulation, right? If it says 5 milligrams on the tablet, it is 5 milligrams, because that's not necessarily the case with supplements. That you're not necessarily getting what it says on the label in the tablet. There is an organization called USP that validates these supplements in terms of content. You know, that, you know, 5 milligrams on the label means 5 milligrams in the capsule. So looking for that labeling by USP helps sort of validate a little bit on those. But yes, red yeast rice works, but it is equivalent to taking a small dose of a statin.
Okay.
Yeah,
Thank you so much.
no problem.
Question on Ozempic,
Ozempic,
is it weight loss? Yeah, now, what do you think of that?
I love it.
Okay.
I'm a big fan of these weight loss medications. Ozempic is the diabetes version. Wegovy is the weight loss version. They're the same exact drug made by the same exact people. It's a same girl, she's just wearing a different dress. One's going to the buffet line and one's going to a party. All right, so one is for diabetes, and the other one is for weight loss in the non-diabetes patient. They are not covered by Medicare. So the weight loss versions, unless you have diabetes, are not covered by Medicare. They are covered if you've had a heart attack or stroke. They are covered, the competitor, which is Zepbound, is covered if you have obstructive sleep apnea requiring a CPAP. Weight loss alone, they're not covered. I like them, they're good drugs. I've seen a lot of, you know, patients who are overweight, you know, lose weight, drop their blood pressure, drop their blood sugar on these medications. They do have their side effects. A lot of patients are worried about long-term, you know, what we know is about 8 to 10 years worth of data. We don't know beyond that. So, but we know 8 to 10 years that nothing has reared its ugly head. So. Yeah.
Those are always injectables. They're not.
Yeah. There is a diabetes pill, which is the same drug as Ozempic and Wegovy. It's called Rybelsus. You're gonna hear in the news of, oh, they're coming out with the diet pill now, right? They're just marketing the Rybelsus for weight loss. So they're gonna take what they already have, go to the FDA, get it approved for weight loss, and then market it as the pill. Yeah. So they're all semaglutide. Yeah, so I have quite a few patients on these, and I am a fan of them because I've seen them do good work. So,
Linda, what about the muscle mass? Some
Muscle-
doctors don't prescribe it because of that.
so muscle mass loss is from the weight loss and not from the drug.
Exactly, but if they lose weight, they're losing muscle, so if
Yeah,
they
but
don't
if
exercise.
correct, that's the key. You have to exercise. You have to exercise. You have to do strength training. If you lost significant amount of weight by intermittent fasting, you would still lose that muscle. So it's the weight loss, not the drug. And it's about maintaining your muscle integrity by doing strength training. Yeah, so. Yes.
What's your take on probiotics
Um,
for gut health?
I don't actually have an opinion on them. I don't take them myself, but I think there are patients who benefit from them, who struggle with, kind of diarrhea, mostly with diarrhea that patients take it for. I think they're safe. But I don't have much of an opinion on those.
Any other Zoom questions? I'm gonna shut the Zoom portion down here. We're good?
Okay.
All right,
All right.
guys.
Thanks,
Thank
everybody.
you.
All right. Anybody
Bye.
here? Okay. All right. Thanks, everyone. Yeah. All right. Close this down, Linda.
Let me do that.
Okay.
You wanna make sure that we.
Quick question.
Mhm.